Good afternoon, everybody, and my dear colleagues. We are quite honored to have a chance to talk at the prestigious 67th Myanmar Medical Conference on the ACC by various very eminent hepatologists. And before I start, I would like to talk about a few housekeeping rules. One is please stick to your allotted time, exactly 12 minutes. And may I request all the participants and all the panelists, except the speaker, please, somebody is presenting or speaking, mute all your microphones. So hepatitis C is a very important, and we have launched hepatitis C elimination according to WHO's guideline a few years back, but we are having problems with the COVID, and in the middle of all the troubles, we have started this HCV education program for the medical professionals. So the first speaker will be Professor Cho Sothun, Honorary Professor from the Defense Services Medical Academy and Chairman of the GI Liver Foundation Myanmar. Professor Win Nine will start. Professor Win Nine is a former head of Department of Hepatology from the Institute of Medicine, One Yangon. Professor Win Nine will be speaking about maximizing the HCV care. Professor Win Nine, please.
Thank you, Mr. Chairperson. Thank you, Sergi, for your kind introduction. Let me share my slide, please. So my topic is how to maximize HCV cure. So hepatitis C is used to be a lifelong infection for most of the people, and only 15 to 25% clear Hep C from their body without the treatment. So other percents for everyone else, hepatitis C become chronic, and with advances of the hepatitis C treatment, most of the people cannot be cured. Many people do not seek the treatment for the chronic hepatitis C infection because they do not know they have the hepatitis C infection. This is a problem in our country. So we have a delay in the elimination of the hepatitis C in our country. It is the only years later when the hepatitis C leads to the serious health issue, they seek medical advice, and it is a late condition. We cannot try to cure the liver diseases. So early intervention is very important before the hepatitis C destroy our liver. So our recent guideline mentions that all patients with a chronic hepatitis C infection should be considered for the treatment, regardless of the fibrosis stage or presence of co-infection, except pregnancy. However, if you have a limited resources, there are prioritized populations like patients who are at fibrosis stage of F3 and F4, patients with decompensated cirrhosis, and patients with HIV and HCV co-infection. So our goal of the hepatitis C therapy is to cure the hepatitis C infection in order to prevent the complications of hepatitis C related liver diseases and extrahepatic liver diseases, including hepatic necroinflammation, fibrosis, cirrhosis, and decomposition of the cirrhosis, and finally hepatocellular carcinoma. We can cure the severe extrahepatic manifestation, and we can finally avoid the death due to hepatitis C infection. Apart from that, after treating hepatitis C infection, we can improve quality of life and remove the stigmata of the hepatitis C infection. And on the other hand, after treating hepatitis C infection, we can prevent an onward transmission of the hepatitis C to the other persons. So up until a few years ago, only 2 medications options exist for the hepatitis C treatment. Now there are several medications, including direct antivirals, and these drugs can lead to the 90 to 95% cure rate. So very high cure rate for the hepatitis C infection with the direct antivirals. So initially, the eligibility of each medication depends on the type of the hepatitis C infection. This is genotype of the hepatitis C. So we call it genotype-specific treatment. Nowadays, there are pan-genotypic antiviral drugs become popular and that maximize the cure without needing to test hepatitis C genotypes. However, it is important to take the medications as directed, and not every drug is right for every person. So personalization is very required. Some medications are not suitable for decompensated cirrhotic patients, or some medications are not used for the HIV or HPV co-infected patients and the patients who had liver transplants. So to maximize the hepatitis C cure rate, there are many things to be done. So before studying the antiviral therapy, thorough review of the recent problems, past medical history, including the past treatment of hepatitis C infection, drug history, thinking and mind in the drug-to-drug interaction, and social and financial background, mental maturity for adherence to the treatment, and overall health and comorbid diseases should be done. Then we need to dedicate a treatment plan to establish and explain the concern to the patients, and which is vital to stick this plan and mention possible side effects. So pre-treatment counseling and regular follow-up during the treatment is mandatory for assessing the adherence and monitoring the side effects. So we also need to discuss the avoidance of unnecessary medications, herbal therapies to make the hepatitis C drugs less effective. And we advise to join the local hepatitis C groups to find emotional support, to connect and share stories, as well as to go for the help as it needs. So these are the things we have to do for the maximization of the hepatitis C cure rate. And data for the real-world experience of the treating hepatitis C revealed that patients infected with a genotype 3 cirrhotic patients and previous treatment failure are emerging as new difficult to treat population. Current RAD antivirals are very effective and have a very fewer contraindications, but it is necessary to make the most of the finite resources, and we have to maximize the cost effectiveness of the therapy. So when we choose the medications, it is very important to consider the cost effectiveness. The most important factor in the treatment success is adherence to the treatment recommendation. So pre-treatment education is very important, best strategy for the maximizing the adherence. So adherence declines after 6 weeks of treatment, and we need shorter treatment for the adherence. So these are the hepatitis C drugs, direct antivirals approved in Europe in 2018, and nowadays they are recommended for the hepatitis C treatment. So we have a pan-genotypic drugs for the drug combinations like sofosbuvir, and velpatasvir combination, sofosbuvir, velpatasvir, and boceprevir combination, and gliclazide and pyrentexvir combinations. So these medications are pan-genotypic. It can be used in all genotype of the hepatitis C infection. However, some genotype-specific drugs are still used in treatment of the hepatitis C infection, like sofosbuvir and leribasvir combination, ombitazvir, pariprevir, and ritonavir combination, texabuvir, gracibuvir, and albasvir combination. So these drugs are genotype specific, and we need to test genotype before setting the drugs. Nowadays, sustained virological response is not anymore any challenge. You can see the SVR rate is nearly 98% to 99% in all combination of the drugs. For example, Soblet combination, genotype 1 to 4, the combination, the SVR rate is 96 to 97%. Sovel, genotype 1 to 6, 98%. Grazoprevir, albasvir, 96%. Gliclazide, pyrentexvir, 99% to 96%. And sofosbuvir, velpatasvir, and boceprevir combination is round about SVR 95 to 97%. So you can see a very good response of these new direct antivirals. So this is a direct antivirals, but some patients have failure. We call it direct antiviral failure in the USA. 124,000 patients will be in the failure in USA, 47,000 patients in Europe country, and since 2050, near all patients will be the NS5A failure. So there is a problem. So we need to cure the hepatitis C infection. We consider about the failure patients. So resistant consideration is like that. Which class are prone to resistance? Protease inhibitor, NS5E and non-nucleotide NS5E inhibitors are very prone to resistance. We think of the barrier to PI and NS5E resistance is higher in genotype 1B patient versus genotype 1E. So most of the patients in the failure of the current DA have emergent resistant associated substitution. So we have a problem with resistant associated substitution. 15% of patients have baseline NS5A resistant resistant associated substitution and variable effects on genotype 1A response. As we need to consider second generation drugs for the treatment of these resistant associated variants. So you can see this is a effective response of the resistant associated substitution. So nearly 86% have no ref, but 14% have ref for the genotype 1, 36% no ref, and 64% for the genotype 2, and 24% no ref, and 76% ref in genotype 3. So you think of genotype 3 has a lot of resistance associated substitution. However, we have a new options. This is for the these resistant population. We have a sofosbuvir, valproatovir, and bosilibrivir combination. We have a gligabrivir, pibrentasvir, and sofosbuvir combinations, which are used for the new option to treat the resistance. So you see overall response of these combination is 97%. However, NSIB inhibitors, the response is 96%, and other DEs resistant associated variant, the response is 97% with a sofos and then bosilibrivir and valproatovir combination. So you can see there is a difference in between sofos combination sofos. Without cirrhosis, sofos was a little bit higher response, but with cirrhosis, a lot of difference in between 96% SVR and sofos compared to the 86% response and sofos combination. So definitely sofos is better than a sofos. However, we cannot use sofos in case of the advanced cirrhosis child group B and C cirrhosis. And the GB regime, gligabrivir and pibrentasvir regime, it can be used 12 weeks or 16 weeks. The breakthrough biological relapse after 12 weeks is SVR is only 89%. 8 weeks is SVR about 91%. Through a better response in the 8 weeks combination of the GP. And if there is a cirrhosis, the response is a little bit lower. So we can combine with the GB and ribavirin and compared to the 12 week and 60-week regime. For the non-cirrhotic, the GB regime in between 16 weeks and 12 weeks is more or less the same. So GB can be prescribed 12 weeks for the non-cirrhotic patient. However, if that is a cirrhotic patient, we better combine with the ribavirin. Another one is Megalens. This is evaluate efficacy and safety of the sofosbuvir plus GB and ribavirin for 12 to 16 weeks. So you see a lot of difference in the genotype 1, especially genotype 1A, but genotype 2 and genotype 3, the sofos and GB plus ribavirin for 16 weeks is option for genotype 3 who have failed to previous treatment gligabrivir and pibrentasvir. So we have a difficult population, genotype 3, so we can combine with the sofos, GB and ribavirin for 16 weeks to get a nearly 100% SVR. So in conclusion, to maximize the hepatitis C cure, before starting the treatment, we need a comprehensive clinical and biological evaluation, and patient needs should be individually addressed to maximize the adherence. This is we call it personalization of the treatment. And we have considered 5 basic concepts apply for the selecting of the appropriate regime, viral genotype, prior treatment experience, presence of the cirrhosis, comorbidity, and renal insufficiency, etc., and concurrent medications that interact with the direct acting intervals. HIV co-infection is no longer a factor of affecting SVR, but DDI and risk of infection is kept in mind. A special program to follow-up visits should be established to monitor adherence antiviral therapy and potential side effects and direct antivirals. For the treatment failure patients, we consider reinfection as a cause of recurrent viremia, assess adherence persistent prior to the regime, assess genotype, assess liver disease stage, no cirrhosis, or child group B and C, and if there is no cirrhosis, single DA failure, we restart with at least 2 DA plitidine to achieve based on the prior DA use. Direct use of the triple regime for 12 weeks is also considered, SOVAL and VOX or SOV and GB regime. Now, rest testing is not recommended, and cirrhosis or prior treatment therapy with both NS5 and NS3 protease inhibitors. Consider triple regime, SOVAL, VOX, or SOV and GB regime. On adding ribavirin and extension of the duration, that means 16 to 24 weeks is necessary for the treatment of the DA failure patients. So thank you very much for your kind attention. This is the end of my presentation for the maximizing of the hepatitis C cure. Thank you.
Thank you very much, Professor Winine, for your very comprehensive and up-to-date presentation on the maximizing treatment of HCV infection. I would like to invite the next speaker, Professor Chosutun, for the presentation of the treatment of HCV in the special population. As I have said earlier, Professor Chosutun is the current president of the GI and Liver Foundation, Myanmar, and also honorary professor, the Department of Hepatology of the Defense Services Medical Academy. The usual presentation of the Professor Chosutun's are excellent, very beautiful, kind cartoons and pictures. And Professor Chosutun, please.
Thank you, Jay, for your kind introduction. Hello, everybody, all my colleagues. Today, I'm going to present about HCV treatment in special populations. I've got nothing to disclose. So this is a beautiful picture of a deadly HCV. So by definition, the special population means is generally used for a disadvantaged group. But in hepatitis C, the special population we mentioned are those who merit special considerations because of their suboptimal outcome from the standard of care DA treatment or drug-to-drug interactions or possible adverse events. So these are the special populations. Because of the time limitations, I can't cover all, so I will cover most of the salient ones. First, it is the acute or recent hepatitis C, and it is defined as the first 12 months following HCV acquisition. The HCV RNA is positive and the antibody is negative, so we can call it an acute HCV. Before the interferon era, it is wait and see policy because the spontaneous clearance rate is 15 to 33% chances. So we wait and see. If it doesn't cure spontaneously, then the treatment sets in. But in this safe and effective DA era, it is a test and treat strategy. So we are now, so the recommendations are emphasizing on treating the acute or recent hepatitis C. This is the algorithm. And then this is the testing recommendation for acute hepatitis C. The treatment is the same as what Professor Winine has already stated in chronic hepatitis C. One thing I would like to remind you is that there are ongoing studies which tries to shorten the course of the ACV therapy. Now, this is the GP regime and this target 3D cohort, and using 8 weeks. And then the SVR12 rate is very good. And according to the paper, the most privileged ones who can have 8 weeks of treatment is the one with a low viral load. With the high viral load people, there are chances of relapses. There are 8 weeks treatment of in other regimes, and then the further studies are going on software and the targeted 3D phase 3 for GP for 4 weeks. So if we can shorten the therapy, it is not only the cure rate, but the cost and the patient compliance will be very much improved. The ACV infection in women of childbearing age, every reproductive age, women should be tested for ACV, and then if they had an ACV, they should be treated before pregnancy, because there is no robust clinical trials stating the safety of DAAs in pregnancy. But a few data show us that ACV and DAA treatment in pregnancy is quite safe. So it is going to be the individual basis for patient-physician discussion, counseling, and taking potential risks and benefits. If we can treat it, we can cure the ACV, and we can prevent maternal to child transmission. And we can, if we don't treat it, then there won't be any side effects, but there is risk of maternal to child transmission, the virological relapses, and so on. These are the data of safetiness of DA in pregnancy. The GB, Letsoff, and Valpartesvir are quite safe. And the response rate is quite good as in pregnancy as in non-pregnant women. And the safety, the side effects are quite mild, like nausea, vomiting, diarrhea, and then the fetal abnormalities are almost nil. So to initiate treatment or not to initiate treatment is the consideration of current time. And these are the safety of DAs in pregnancy. Majority of the DAs and the FDA pregnancy category B. Only Clazoprevir and Teclidecvir are in consideration. Regarding about the children, previously we don't recommend treatment in children. Only adolescents are treated. Now, children can be treated with newer DAAs. So they should be testing. The child born from the ACV infected mother should be tested for ACV, anti-ACV antibody at 18 months. If they want to test earlier, they should test an ACV RNA PCR test. That is in 2 months of age. And then if they had positive transmission, we can treat the child at the 3 years of age. The treatment is on weight basis. We can use soft-lead, soft-valve combination, and GP combinations. These are the dosage guidance for treating in pediatric patients. So the maternal to child transmission is the most common cause of ACV in children. And 25 to 40% of infants clear ACV by 2 to 3 years of age. But there is a substantial impact of ACV infection in maternal MDCD infected children. They had reduced physical functioning, the executive function impairment in 20% of children, and worse is the cognitive function defect in children with ACV. And there's a higher rate of cirrhosis and ACC in those children who acquires ACV through maternal and child transmission. So another thing is the reinfection. The DA failure, Professor Winai has covered the DA failure. I would like to talk a little on this reinfection. The reinfection rate is not so high, 0.9%, but in the IVTU, PWITS, and the HIV co-infected patients, there's a substantial amount of reinfection. And the reinfection rate for the first time is 7.6 per 100 patient years. But when you had a one reinfection, then the chances of second reaction is very high. That is 19.9%. In other countries, to minimize the reinfection rate, they use opioid substitution and needle and syringe programs for these patients using PWIT patients. And this is the one unfortunate patient who had 10 times of reinfection. And these are the genotypes during the reinfections and the treatment and the responses to the treatment. Is it a relapse or a reinfection? According to, if you see the phylogenetic tree, it clearly proves that it is the reinfection and it is not relapse of ACV. Regarding about the sexual transmission of ACV, the rate of sexual transmission is very low, around about 4%. And it needs approximately 190,000 sexual contacts to have to contract an ACV in a heterogeneous monogamous couples. But in MSM, you can see that the rate is very high. Sorry. The chances of contracting ACV in blood is 10 to 20 particles, but by inner contact, exposure is 2,000, nearly 2,500 international unit of ACV for the duration of anal intercourse. So there is a high chances of ACV contraction, much higher than in the PWITs than in this MSM group. So now there's a, in these days, there's a sham, what you call sham night, people having a group sex using methadone, or using these stimulant drugs. And this is where the ACV transmission has been dangerously contracted. Another one I'd like to touch on the hepatitis C in chronic kidney diseases. If you had a hepatitis C, the decline of GFR is very fast. And then the metabolite of sophos is toxic, renal elimination, it is toxic to the body. And the other DAS are also they're also affected in CKD patients. So it is better to send to the specialist for the treatment. For co-infections in the SARS, there's a hepatocellular mixed pattern, and then it is during the what you call cytochrome state that the liver is severely infected. Hepatitis B and C co-infection, usually hepatitis C is dominant because the hepatitis C protein suppress the hepatitis B replication. And then this co-infection has worsening fibrosis and high incidence of HCC. The treatment So you need to treat hepatitis B at the same time with the HCV. And then HIV, there's accelerated fibrosis with HIV. The treatment response is the same with non-HIV patients, but there is a very severe drug-drug interactions with antiretroviral drugs. So we need specialist treatment in this too. These are the drug-drug interaction with the DAAs, and then for your reference, I have put in. And regarding about the life expectancy, if you have less than 12 months chance of living due to the non-liver related comorbid conditions, there is no point of treating HCV treatment. So regarding about the treatment in DA failures, Professor Wenai has been covered it. Hepatic solid organ transplant recipients, patient of HCV organ transplant, and hemoglobinopathies and ACCs. So I will present it in another presentations. So hepatitis C cure is costly, and there are a lot of challenges, as Professor Wenai has stated. So we need to overcome it, and it's worth overcoming. We treat HCC as not only as a treatment, as a prevention strategy. But while treating HCV, it is not only to stop onward transmission, but we need to take care of the prevent reinfections by education, sexual risk reduction, and safe drug practices. I would like to end my presentation by this slide to spread the word that there is a cure for hepatitis C. And GI Endeavor Foundation Myanmar has been here to help everybody to treat hepatitis C or eliminated hepatitis from Myanmar. These are my references. And thank you very much for your kind attention. Thank you, sir.
Thank you very much, Professor Josudun. As usual, you cover a lot of things, which are updated and very interesting presentation. The next speaker is Professor Nyomi from Head of Department of the Department of Hepatology, Yangon Specialist Hospital. Professor Nyomi will talk about the management of patients after achieving cure of HCV infection. Professor Nyomi, please.
Good afternoon. Today my assignment is management of patients who achieved cure of hepatitis C infection. I have to say thanks to MME Organizing Committee and SEPTA and all the participants. I have nothing to disclose. Today I will talk on a little about introduction, hepatic benefits of SVR 12 versus SVR 24. Do we need to test periodically HCV RNA, guides for follow-up and surveillance, endoscopic monitoring after post-EV SVR, and concern about the hepatitis B reactivation, and finally, summary. Curing of the hepatitis C virus infection primarily aims to prevent severe liver compensation, avoid transmission of the virus, and to increase the quality of life. Patients achieving virological cure or sustained virological response have better outcomes than non-responders at all disease stages. In the DAA era, an undetectable HCV RNA level 12 weeks after the completion of therapy, or SVR12, define the treatment success. It means cure of hepatitis C virus infection. The ultimate hepatic benefit of the viral clearance is proportional to the functional class of the liver disease, inversely proportional to the stage of the liver disease in terms of size of the effect. So you can clearly see in this diagram the earlier the stage of the liver disease, the less the fibrosis process, and then the greater the impact of overall mortality and improvement in the quality of life. After having a significant fibrosis or cirrhosis, whether compensated or decompensated, you cannot get the full benefit by curing the hepatitis C infection. Virologic cure will reduce, but not eliminate the risk of the liver-related events. Therefore, the benefits of the SVR in liver disease becoming less and less by increasing the stage of the disease. I would like to highlight the management of the patient with SVR12 Hep C cure by asking 5 questions. Once a patient achieves SVR12, is periodic confirmation of the hepatitis C RNA ever needed later on? SVR12 has a positive predictive value of SVR24 of more than 97%. The risk of losing SVR is very remote unless there is a risk factor for the HCV reinfection. People are quite reluctant to get reinfected or to get relapse. Therefore, they usually, or doctors as well as the patients, test the HCV RNA again and again. So do we need really to retest the HCV RNA? So you can clearly see in this figure, the late relapse is very rare. This is the 5-year cumulative risk of the recurrent post-SVR Hep C infection according to the risk groups. High risk group means PWIC or men's sex with men or something like that, and RVI. These are the high risk group. Low risk group, no risk factor for the high risk people, high risk condition. So in this, late relapse is very rare. So getting reinfected is very remote. Another one is according to the current American Association for the Liver Disease, mentioned that once SVR12 or 24 is achieved, no verification is needed at later time points unless the patient's liver results becomes abnormal. If something like a ALT or AST goes up off and on, otherwise you need not to retest the Hep C RNA. EASL stated that repeated testing for SVR 24 to 48 is recommended, although SVR12 is highly predictive of a durable virological response. So it means you can retest the HCV RNA maybe after 6 months or 1 year after SVR12 has achieved. Another question, question 2, should virologic cure patient with less than advanced fibrosis, that means mild fibrosis, F0 or F1 or F2, undergo screening for HCC. DAA reduce the incidence of HCC. You can clearly see in this chart, patients with SVR has very low incidence of HCC. You see, if the patient has no SVR, the incidence of HCC is quite high. This is the study, cumulative incidence of HCC among 22,500 patients treated with DAA regimens. Therefore, you can note that the cure does not eliminate the risk of HCC in previously infected patients. Therefore, accurate assessment of the fibrosis and assessment of the coexistent liver diseases, such as alcoholic liver disease or non-alcoholic fatty liver disease, are necessary to determine to make a follow-up to call patients, please come to visit us after having SVR. In patients with lesser fibrosis, F0 to 2 with SVR, they may be discharged from the specialist care, but you cannot discharge them from the care if they have cofactors for the fibrosis progression, such as alcohol or obesity or metabolic syndrome, just although the patient has got SVR. Patients with advanced fibrosis, F3 and 4, have a substantially lower risk of decompensation and ACC, but still remain at risk. Therefore, lifelong surveillance is essential for them. These are the factors influencing the future risk of liver-related complications. The well-established associations are cirrhosis and presence of portal hypertension and low platelet count. The other factors are maybe frequently reported associations or less consistent associations like obesity or diabetes or alcohol or elderly. Question number 3, is ACC screening needed in SVR patients with regression of the advanced fibrosis or cirrhosis? We do know that if we treated the decompensated cirrhosis, they improved a lot. So you can see in this slide, 74% improved, only 6% worsened the condition. Therefore, this is the improvement in the liver function by means of Child-Tucker-Pugh class. You can clearly see, but interestingly, Child B patient did not improve as much as Child C patient. However, it does not equate the fibrosis regression. Therefore, currently we don't have no clear guidance on the surveillance of ACC to guide the patients who got fibrosis regression after post-SVR. Therefore, I would like to remind you that because of the abundance of caution, liver stiffness measurement and non-invasive markers of fibrosis, like a EPRI or FIT4 or whatever, FibroScan, you cannot use to safely determine when a patient is finished with ACC screening. Another one is routine follow-up is necessary for screening of esophageal varices in all SVR present patients. If the patient has liver stiffness more than 20, endoscopic monitoring is necessary, as well as platelet count less than 150. However, if the patient has already got small varices and after SVR, they have ongoing liver injury, endoscopic monitoring must be done annually. But if there is no varices and no ongoing liver injury post-SVR status, if the patient has cirrhosis, we have to do endoscopy every 3 years. Another question, the last question is, should SVR positive present patient be monitored for reactivation of their HEPI infection? Yes, we do need to monitor them because there is a lot of evidence for the hepatitis B reactivation. Recently, US FDA has called for the monitoring any patients who have anti-HBC co-antibody positive. It's a very big issue because many of the Hep C infected patients have got hepatitis B co-antibody positivity. This is my last slide in summary of the recommendations. All persons who achieved SVR must do RNA testing only after SVR 12 only once. You need not to repeat again and again. Then optimize your metabolic control, diabetes, obesity. You have to avoid, patient has to avoid illicit drug use, hepatotoxicity, and alcohol abstinence. If the patient has high risk of infection, reinfection, and your Hep C ACV RNA testing has to be performed, and we need to counsel the patient not to, by encouraging the risk, to avoid the risk of reinfection. Now, there are some additional recommendations by ultrasound alpha fetal for Hep 6 monthly for ACC surveillance, and ultrasonic upper endoscopy for portal hypertension and variceal bleeding risk. And lastly, we need not to forget the clinical evaluation for any progression, any signs of progression to the cirrhosis or decompensation. Thank you very much.
Thank you very much, Professor Nyumi. And I have to tell about Professor Nyumi post-presentation. And she's a very active in academic activities, and she spent 1 year in Japan doing the molecular works on the hepatitis B and C. So she's the right person to talk about the post-SVR care. Thank you very much. The next speaker is Professor Wen Sui, Head of Department of Hepatology, University of Medicine 2, and Professor Wen Sui will tell about achieving ACV elimination. Like I said in my introduction, it will be a little difficult now because of the COVID-19. Professor Wen Sui, please.
Yes, Tian. Good evening, all my CRG, and today I will talk about the achieving ACV elimination in Myanmar. ACV infection, which is a mainly a blood-borne viral infection, it's a global public health problem in which, according to the 2015 data, prevalence of the anti-ACV in general population is 2.65%. This is a burden of ACV infection in Myanmar, in which AC prevalence is highest in the Moon State, Molamyang 10.3%, and lowest prevalence in the Bago Chin 0.3%. So when Myanmar among the 15 to 80 years has hepatitis. Regionally, South Asia region of the WHO estimated 30 million of people living with the chronic C infection. So parahepatitis is a very important one, and WHO organized the elimination of the hepatitis C infection worldwide, in which on May 2010, the World Health Assembly Resolution 10 and also December 2011, Global Hepatitis Program established. The WHO guideline appeared 2014. And Myanmar National Hepatitis Program will start over 2014. There, the simplified programmatic approach follows 4 recommended key ACEs. ACEs 1 is the increasing awareness of the policymakers, health professionals, donors, and stakeholders, in which first national consultative meeting first national consultative meeting finished November 2014, and it has the many national strategic plan for hepatitis. SS2 is the evidence-based policy and advocacy, in which the nationwide prevalence survey of BNC and BNC 10 in the 2015. SS3 is the prevention of the transmission, primary, secondary, and tertiary, in which the blood donor screening, hepatitis B vaccination, and similar treatment guideline for hepatitis C. SS4 is a screening, care, and treatment, in which capacity building, health resources, screening, and diagnosis are many programs, and also supply and logistics are very important. Government involvement on NHCP towards the viral hepatitis elimination. Among these, system building blocks are many. There are service delivery, health workforces, a health information system, access to essential medicine, financing, leadership, and governance. The foreign strategies for ACV elimination in Myanmar: 1 is the harm reduction, 2 is the testing, and 3 is the treatment. Harm reduction, among these, needle and syringe program is a very important one. And also according the education, legal services for infection screening and counseling services. In the better for the partnership for hepatitis, also the NAC program, MOHS, WHO, local NGO, and INGO, all are involved in the hepatitis elimination. These are the most INGO for elimination of the hepatitis C infection in Myanmar. Harm reduction targeted the PV in Myanmar, according to the 2014 and 15 data, increased from the 167 to 123 syringe per year per PV patient. We should recommend the 200 syringe per PV per year. Number 2 is the testing. Testing, important one is the integrated centralized testing, is the NACB, and also patient-centered decentralized services are also involved in the testing. It is a very important one for the elimination of the hepatitis C. Another one is a treatment. A symptom pre-treatment workup and also pan-genotypic DA regime, so for decline and so for verbal regime, plus or minus recovery, and also monitoring of the treatment monitoring and post-treatment care. Another one is micro-elimination. The first step towards the ACV elimination in the South Asia Pacific region is the micro-elimination. Important of the micro-elimination, first is achieve the elimination of the hepatitis C. As this is a care cascade of the ACV infection for all the visual region 2015. This is the emphatic amount and diagnosis target and treatment target in 2030 and cure in 2013. For the ACV elimination, it is a more programmatic approach to achieving this goal, from the micro-elimination to the global elimination. This is a micro-elimination, smaller group with result and effectiveness, but the global elimination, higher scale, complexity, and higher cost. So targets for micro-elimination are subpopulations, people living with HIV, prisoner, people with hemophilia, and children, setting in the hospital or additional center, and also generational or study and also geographic area, a city or region. There's a various population. This is elimination of the hepatitis C, and there are many groups for the elimination. There are one of the micro elimination practice is one population is the migrants. There's a study of the ESL, International Labour Foundation, collaboration with the Foundation ARCA for the ACV elimination in migrants. Another one is the STOP-C study. Also, this is evaluate the impact of rapid scale-up of the DA treatment on instant and prevalent ACV in the present setting. The combination of the micro elimination projects can make the regional elimination a reality. It is important to engage all stakeholders to ensure strategies are tailored to the specific needs of the each region and targets are achievable. It is micro eliminations are governments, technically innovation, primary care provider, hepatologists, other healthcare specialists, policymaker, researcher, medicine, procurement, patient organization, and civil society. There are many barriers in ACV elimination. Legal restriction, burden on other products, infection in Myanmar, eczema, HIV, TB, malaria, fragmentation between government and NGO service, patchy coverage of the harm reduction services, poor service access, less health knowledge, and stigma or disease and risk behavior. But there are many opportunities for the ACV elimination in Myanmar. Changing policy and registration, set at one of the products, diseases, health system decentralization, fragmentation to collaboration among the public, private sector, and NGO and INGO, and country-specific negotiation of the DA pricing. For my presentation, summary, all ACV information need to be screened and linked together to achieve the ACV elimination. ACV elimination is the ambitious micro-elimination offers a more pragmatic approach to achieve this goal. Micro-elimination strategies in the Asia-Pacific region need to recognize the difference in prevalence, risk, and challenge between countries and tailor strategy to meet their local situation. ကျမတို့မြန်မာနိုင်ငံမှာလည်း micro elimination လုပ်ဖို့ကျမတို့စီစဉ်ထားပါတယ်မြို့တစ်မြို့စီစဉ်ထားတယ်အဲ့မှာဆိုလို့ရှိရင် safe supply နဲ့ကြပါ NACB program နဲ့ကျမတို့သွားမှာဒါပေမဲ့အဲ့ချိန်မှာကျမတို့ပြဖြစ်သွားတဲ့အကြောင်း micro elimination ကိုအဲ့ data တစ်ခုမှလို့ကျမတို့ရပ်ဆိုင်းခဲ့ရပါတယ် so thank you very much for all your kind attention thank you
Thank you very much, Professor Winsway. Now it is the time for the questions. There are 8 questions. One is, I think, Professor Josoton has to tackle. What is the reinfection rate in Myanmar and what is your experience? Not soon to clip on. What is that? Huh?
Is there any Myanmar data about SVR12 or treatment?
yeah
Sorry, I don't have actual data of reinfection rate in Myanmar. To my personal experiences, I've seen a few cases of reinfection in this, what you call pivot cases, but only 1 to 2 reinfection rate, not that like the one I've shown you on my presentation. Thank you.
Another question is, again, I think I have to direct to Professor Josurum because you are mainly concerned with the treatment. A patient with the pancytopenia, after treating with the DA therapy, will the pancytopenia persist or cured?
If the pancytopenia is due to hypersplenism with cirrhosis, splenomegaly and hypersplenism, it will persist. If it is due to extrahepatic manifestation of hepatitis C, because you see hepatitis C is a chronic persistent infection, it has ways of immune manipulation. So it is manipulated by this what we call platelets, antibodies and everything, they can be still persist, but still there's a chance of cure also for this extrahepatic manifestation. They can definitely be slowed down.
Thank you. The next question is, what is high viral load or ACV infection regarded as high viral load in this country? Professor Nyomi, please. Yes.
Yes. I don't actually understand what level is the high viral load for ACV in here. We don't have any local data for the high viral load, but internationally, we usually regard the high viral load as a 400,000, 4.0, more than 4.0, 10 to the power 5, log 5. No? Thank you.
Even then, I do not think that there is any significance in the viral load because with all the newer DA therapies, regardless of level of viral load, the SVR rate is the same.
Yes, exactly, CIE. You are quite right to point out the level. The level of the viral load does not have an impact on the sustained virological response or Hep C cure. Thank you very much.
Another question is, what is the ACV infection rate in the multiple transfused thalassaemic patients? That the Department of Hepatology, Yangon General Hospital, and Professor Nyomi, if you remember, ourselves and the Japanese hospital, Professor Hamashima Shikada, I don't remember, and the development, we have done a study and it has been published. I don't remember the actual rate, but it has been published. Another is, if you are going to treat the thalassemia patients with a DA, what drug will you choose and how will you model? This will be, I think, to Professor Josoton for the special population. Yes, Professor Josoton, please.
Yes, if depends on the underlying liver condition. So I can choose a pangenotypic, and then the duration will depend on the liver fibrosis. And I think the cure rate will be the same as the other persons because there is no drug-to-drug interaction for thalassemia patients. The only thing is how damaged is the liver before we treat ACV.
Professor Winine, there is one question. Can a case of ACV infected CKD patients transmit another CKD patients without ACV infection by using the machines?
Yes, yeah, according to their study, they mentioned that the transmission from the machine is very less, and the problem is the transmission from the blood or other materials transmitted through these products. The machine is already sterilized, and then the transmission from the machine is very uncommon.
Thank you. Professor Winsway, one question is, how can you know the acute ACV infection?
Okay, well, thank you. Acute ACV infection အနေနဲ့တော့သိရတာနည်းနည်းလေးတော့ခက်ခဲပါတယ်ဒါပေမဲ့လူနာတယောက်က ACV နော် antibody positive ကိုနော် previously နော်6လအတွင်းမှာစစ်ခဲ့တဲ့အချိန်မှာ negative ဖြစ်နေတယ်လွန်ခဲ့6လအတွင်းမှာ 6 month မှာ negative ဖြစ်တော့အခုမှဆိုလို့ရှိရင် positive ဖြစ်တယ်အဲ့ဒီမှာ jaundice လာတဲ့ ACV antibody positive ဆိုလို့ရှိရင်တော့အဲ့ဒါကို acute ACV infection လို့ဒါပေမဲ့အဲ့ဒါ very very rare ပါရှင် Thank you.
The last question is, what is the FCR rate in Myanmar and what are the resistant genotypes? That myself, our department, and Professor Nyomi together, we have 2 or 3 publications. And I don't really remember the rates, but you can look for with my name and with Professor Nyomi's name, and you can find out what are the resistant genotype, what is the SPR rate. This will be the last question. And the time is up. And thank you very much, all the speakers. Thank you, the organizers, for inviting us. And thank you, Inceptor, for your academic support to this symposium. And we are very glad that we have a chance to talk about single focus disease on the hepatitis C. With this, I would like to conclude this symposium. Thank you all.
Thank you.
Thank you.
Thank you very much. Thank you.
Thank you. Bye.
Bye.